Most students are introduced to the heart through anatomy, chambers, valves, vessels, orientations, labels. You're expected to memorize these structures often in isolation, and then later you're going to apply that to physiology, pathology, patient assessment, and medication management. On paper, it looks logical. In practice, it's actually going to cause you a creative and cognitive bottleneck. Uh, Reject that siloed approach. We Anatomy without an organizing principle just becomes trivia. And that's actually really sad because anatomy is far too valuable to be treated as trivia. It's easy enough to say that your trivia that you know can be regurgitated while you're writing an exam, but under clinical pressure, trivia is more likely to collapse from overload. Too many inputs, not enough structure, uh, anxiety rises, and your recall becomes unreliable when it matters the most. So I'm here to overturn that default learning system so that your prep for clinical practice is integrated, it's organized, and you prioritize systemic learning and thinking and generate focused reasoning in the face of pressure. Hmm, pressure. I was just thinking of a song there. Never mind. Pressure destabilizes systems, biological systems, learning systems, everything. And it's really important as we go through different topics to assign blame, assign failure to the structures and processes that create instability, and we want to replace them and replace their inefficiency with continuity. I recommend you push back against the pressures, and that's the way forward. At its most basic level, the heart exists to move blood. When blood can't move forward efficiently, pressure builds. The heart compensates for a time, sometimes for a very long time. Heart rate increases, cardiac muscles adapt, hormonal systems activate, the system holds together. Then at some point, another stressor adds too much to the load. An infection, dehydration, overexertion, and suddenly the patient decompensates. The collapse looks sudden, but the strain has been accumulating for years. And that's not a simplification, it's actually a clarification. Blood must move in one direction at an appropriate pressure. It's got to go to the right places at the right time. Tissues are perfused, oxygen and nutrients are delivered, waste is removed, and systems remain stable when it happens according to plan. So instead of using only anatomical terms, the heart is actually a system of flow under pressure. And that's the song I was thinking of. So there you go. A living system that moves blood continuously. It adapts to changing demands. It reveals strain through predictable patterns. And once you understand that anatomy, physiology, clinical assessments, they stop competing with each other. They start reinforcing each other. So let's organize some information today and just get that going. Um, blood returning blood returning from the body enters the right side of the heart. This blood is low in oxygen. It's high in carbon dioxide and metabolic waste. The right heart's task is to send that blood to the lungs. This is a relatively low pressure system, and it makes sense, right? The lungs are close to the heart. They accept large volumes of blood, so the low pressure works to prevent damage. After gas exchange occurs in the lungs, oxygenated blood returns to the left side of the heart. The left heart sends that blood out to the entire body. This requires much higher pressure because blood has to travel to every tissue. It's going from your brain to your feet against gravity and against all the systemic resistance. Already several important things are visible when you think in terms of flow. The heart is effectively two pumps sharing a common wall. The pumps are operating in series, and each one is influencing the other. The two sides of the heart are not interchangeable. They face different workloads. They're structured differently. They adapt differently under stress, and yet they are inseparably linked. If one side struggles, the other will eventually be affected. Uh, a problem a problem that begins on one side of the heart, it rarely stays there, as we'll see. So, identifying chambers, valves, major vessels requires more than memorizing labels. Begin by recognizing landmarks along a continuous journey and connect the structures to blood flow. When you follow the blood, the anatomy organizes itself logically. You must understand how blood moves through the heart in sequence. Blood enters, it's redirected, it exits, and at each stage, structures exist to support or regulate that movement. When those structures fail, flow changes, and when flow changes, pressure changes. When pressure changes, symptoms appear. Take valves, for example. Valves exist to enforce one-way movement through regions of pressure changes. Valves matter because they prevent backflow. Chambers matter because of what they receive and what they send. Vessels matter because of where they carry blood and under what pressure they operate safely. Learn the heart as a story of movement. Stop asking, what is this called? And start asking, what happens to flow if this fails? It's a fundamentally different way of thinking, and it opens up opportunities for even greater insights, as you'll see. On placement, you ask questions like, does this patient look stable? Why are they suddenly breathless? Why has their urine output dropped? Why are they confused when their observations aren't remarkable or alarming? No one's asking you to label an anatomy diagram. These are flow questions. Breath, urine, state of mind. They're answered by flow, you say? Yeah, they are, and we'll cover why. Rather than being a student who feels confused in the clinical moments, organize yourself. Organize yourself to function under pressure and connect the flow to what you know about the patient history and the data on hand. You're going to be reaching out for what feels concrete. You're going to be looking for defensible numbers. Numbers are good, they're safe, they're objective. I get that because numbers are a fantastic lifeline, except when numbers are used without context, that can be dangerously misleading. So, this is where you have to actually leverage what you understand about flow and find the patterns that explain the numbers. You're going to move from rote memorization to tracking flow and then on to recognizing patterns. Pattern recognition isn't guessing. It's the ability to see relationships quickly because you understand how a system behaves when it's stable and when it's under strain. Uh, this skill set actually goes far beyond material that's covered on your exams. So I'm going to use reject a bit, I guess. Reject the exam mentality. Go ahead and get your top marks if you want. That's fine. But don't accept that that assessment has adequately prepared you for entry into that live and in your face high level clinical practice until you've actually aligned the trivia that you learned to go on that exam and align it with structure and experience. Uh, I digress. Uh, Pressure itself isn't the heart's enemy. The enemy is something far different. The heart's designed to generate pressure. Blood doesn't move without it. Problems arise when pressure is mismatched to capacity, timing, or resistance. Too much pressure upstream leads to congestion. Too little pressure downstream leads to poor perfusion. The heart is constantly balancing these forces beat after beat, year after year. This balancing act is invisible when things are working well. We take it for granted until it becomes visible when the system is stressed. That's when symptoms appear, and they're either going to be there barely at all or pretty blatant, depending on how you look for them and when. So kind of shift your learning curve and go to a flow-based thinking over just rote memorization. Think of it this way. When blood can't move forward efficiently, it backs up. That back pressure affects upstream structures. This is why heart problems rarely stay confined to the heart. Back pressure into the lungs produces breathlessness and fatigue. Reduced forward flow to the kidneys reduces urine output. Reduced perfusion to the brain produces confusion, agitation, decreased consciousness. The same underlying disturbance in flow has impacted multiple systems. You start to see the patterns here. What conditions disturb flow? Long-term metabolic stress, trauma, chronic illness, poverty, racism, deprivation. They all increase cardiac load over time, and that's not even an exhaustive list. The heart doesn't distinguish between biological and social sources of pressure. pressure accumulates regardless of origin, and physiology responds accordingly. Think of it at a personal level. Imagine you are the heart. How's your health? How are your pressures? Many nursing students live in a state of chronic compensation. Sleep, if any, sleep is shortened, right? Some competitions to stay up as late as you can studying against your fellow students. Competitions for another day. Your meals are irregular. Stress hormones remain elevated for a time. And your performance, you carry it pretty well, pretty good for a while. Then concentration starts to falter. Your memory fragments. Errors become more likely. These outcomes are predictable physiology that rise from faulty systems, not faulty people. Uh, well, is this the life of compensation that you are going to take with you onto the ward? Your own cardiac and metabolic health readily overlay this material. So you can personalize it just to see how much it really impacts not only you, but your patients. You're not studying anatomy or physiology or metabolism as an outside observer. So personalize it and realize that you are not immune to physiological inevitability. Protect your sleep, your fuel, your recovery. It's what you will be telling your patients. You should tell it to yourself. Look after yourself, because if you get that foundational aspect right, you're developing safe practice, which is critical for recognizing and compiling all of those accurate patterns you need to have to be effective on the ward. Instead of reading or rereading dense sections of text, start drawing arrows, simple diagrams showing the direction of flow, pressure points, bottlenecks. It's going to support your understanding far more effectively than paragraph after paragraph of notes. If you can't sketch the heart as a flow system and explain it to a peer in plain language, the knowledge isn't usable on the ward. Draw flow to understand it. Experience flow to explain it. Teach it to your cat, your dog, a rock. Teach it to a plant or a tree. Test whether your understanding is structural or superficial. You'll be speaking on the ward, so best to start speaking now. We'll have upcoming sessions on some good techniques for getting your thoughts across to patients, family members, colleagues, preceptors. Can look for those later. Treat your cardiac knowledge as something that develops, not something that is assessed at a single point by an exam. Treat it as something that develops through repeated exposure to real patterns and real conditions. Your knowledge is going to be defined far more by your experience than it is by anything placed on a piece of paper for one time point. Often the academic response, if you're struggling as a student, is to have you memorize more things, look at more flashcards, hold more revision sessions. How many times has the call gone out with your classmates? We need to revise and have another session. We've got to do this. Well, make that effective time if that's the thing that you need to do. But don't make it a time where you sit down and copy more and more diagrams from text without any kind of context. That approach is dated, it's old, it's out of touch, and it's a terrible prescription that I just would never recommend it. Don't do it. It mirrors a common clinical error, and that's when you have a system that's under strain. We often add more and more input instead of asking whether the structure itself can handle the input in the first place. Uh, this is actually relevant to some fluids videos, but think about what happens when a heart that's already struggling is flooded with volume. The intent is to improve output. The result is often congestion. The same principle applies across the heart and across your learning. Adding more content to an overloaded system does not make it run better. It's noise, and it can be quite nasty at the end of it all. So establish a learning system that supports your pressure responses, and learn that the heart has got to deal with pressures in a way that is not overpowering it either. Valves can't be understood without pressure. Pressure can't be understood without resistance. Resistance can't be understood without vessel behavior. Vessels can't be understood without metabolic demand. And metabolic demand is shaped by social, cultural, and environmental conditions. If you try to learn the heart as an isolated element, you will feel overwhelmed. If you learn it by following the relationships, you're going to see that coherence will emerge. Uh, even though even though we're not formally practicing patient explanations yet, when you understand the heart as a flow system under pressure, you're already better positioned to explain it in accessible language. You stop relying on jargon. You're not speaking to intimidate. You start talking about movement, blockage, overload, strain. These are concepts people can relate to, and it can go across cultures, it can go across contexts. Good explanations are not simplifying the science until it's far too inaccurate. In fact, uh, yeah, cancel that, cancel that thinking that if you simplify it enough, it's accurate. It's not. You cannot oversimplify, and in fact, oversimplification can be quite harmful. So make sure that your explanations are about choosing associations that preserve truth while reducing the intimidation. Uh, a heart can a heart can tolerate strain for a period of time. It has compensatory mechanisms, and if they're engaged early and appropriately, the heart the heart will carry on. Delay in recognizing the symptoms, however, changes everything. Now that delay can be arranged from years, months, days. This, of course, is going to be a real important reason for having patient history to see where this might come into play. Uh, Delay in recognizing the symptoms. Well, we want to minimize that. We want to minimize it by one, reducing your own heavy cognitive load. Be aware of what you should be looking for, know why you should be looking for it, and then start to put all of the information together. Return repeatedly to the same core ideas: flow, pressure, compensation, capacity. These are reinforcements that are in no way redundant. You've got to establish pattern recognition because it's not something you just get once and then you have a pattern. You've got to see the same relationships over and over again that are being expressed in different ways. Uh, I suppose the other way you can do that is if you think that you're learning in a system that is saying the amount of coverage of material is greatest versus being coherent to you, uh, don't get caught up in that. Stay within a system that says it has to be coherent first, and then we're going to look at how well it covers everything. So stay with me, organize your studies into the placement ready systems. Other things lie ahead. What are some of the myths that tie nurses to pretty fragile models of cardiac function? We'll question why normal is often misleading, why compensation hides danger, and why waiting for certainty can be unsafe. Yeah.